Thank you.
It's fun. It's funny how my familial link to CTEF has changed over the years. From I was a second cousin, then a distant uncle, then now I'm a grandfather. Thanks a lot.
Godfather.
I like Godfather better.
Oh my God. Thanks.
All right. Thank you. My name is Melvin. As discussed, I am the senior fellow at, well, a senior fellow at Duke right now, and I'll be presenting this case. So we have a 48-year-old woman with a past medical history, most notable for hypertension, CKD, and an unprovoked PE, who presents to us for evaluation for shortness of breath in July of 2021. She comes in and she explains to us that she had been feeling short of breath starting around March of 2020. It was going on for about a month. She went to get evaluated and she was noted to have bilateral PEs. At that time, she was started on Eliquis and discharged from the hospital. Over time, while on anticoagulation, she continued to have shortness of breath. I will add in her course, about a month after being diagnosed with the PEs, she did develop a pleural effusion left-sided, underwent thoracentesis, drained it out, never recurred again. But over time, she continued to have worsening exertional capacity. She had some data prior to seeing us. So in May of 2020, she had a TTE that showed a RVSP of 43, mild RV dilation. She then had another one in October, also showed RVSP of 52, still with mild RV dilation. She underwent a right heart cath in April of 2021, and it showed a mean PA pressure of 74, a wedge pressure of 35. She had a PVR of 9 and cardiac index of 2.5. A VQ scan was obtained. And yes. It was reproduced.
Yeah, I mean, it seems unlikely that somebody that age would have that, unless there's something else in the story you're not telling us. Does she have a cardiomyopathy or something else?
No.
Okay. Yeah.
So,
Yeah, it's either profound diastolic dysfunction or they have some systolic dysfunction we don't know about. This just doesn't make sense. I mean, it's probably not an accurate wedge. Yeah. Right. Yeah, you're getting some hybrid signal that's including the PA.
The grace we're giving you is that we're saying that we're giving, we'll put that on the back burner.
Yeah.
That's perhaps not
I
right.
mean, if you're in the cath lab and you see somebody with a wedge of 35, you need to get a left ventricular and diastolic pressure. Even if you're getting the same number in other spots, you got to make sure you accurately assess that. And that's not what I heard in the presentation.
so this was the VQ scan. And as you can see, she has bilateral defects. So at this time, we suspected CTEF and went ahead and started her on Rio Sigwap. At this point, I guess I'll pause because she was referred to for PT evaluation versus BPA, and I'll open it up to the discussants. What information would you need, and kind of like what is your thought process when a patient like this is coming to you?
I defer to the Godfather.
Godfather. You want to this
Monday, Tuesday.
Oh, stop. No, I can go on forever. Do you want to just, I mean, first of all, take a look at the perfusion defects, okay? And you're absolutely right, bilateral defects, but large, particularly in the right upper lobe. So you get a sense now that these are not tiny little, little snippets along the periphery of the lung fields, but they're large perfusion defects, okay? But it's an abnormal scan in a person who has pulmonary hypertension. And that's all you need to know at this juncture to know that further diagnostic testing should be done. This is a non-specific study. It simply is a screening test. So far, everything's done perfectly except for that wedge. And now it's next steps need to be taken.
Yeah, I would say the risk factors that we think about for CTEPH, like hypothyroidism, chronic inflammation, et cetera, all of that's out the window already at this point because we have a pretty clear diagnosis. Now we need to sort of risk stratify and also surgically stratify how proximal the disease is, how severe the disease is. If this were a patient where you hadn't already given me a right heart cath, you just gave me the presentation of the dyspnea, I could go on and on about risk factors, but I think those are less relevant here.
And the appropriate thing was done, a referral pattern, refer to a group that is familiar with CTEPH. And for BPA, PT evaluation, it all comes in. The next steps are diagnostic steps. Is this truly CTEPH or is it something else and one of the mimics? And the second thing that needs to be determined, either by CT and or uh, conventional or catheter-based angiography, is where are the clots in an assessment of operability. So everything's perfect so
I mean,
far.
we often say that the VQ scan is a good way to rule out this disease, but, this is one, obviously, it's very positive, and so you have to go with additional imaging, whether it be CT or, invasive angiography.
All right. So we definitely did that. But before we get to that point, so just thinking of the thought process behind CTEPH and how to proceed, they were referred to a center that can do PTE or BPA. PTE is definitely the gold standard for CTEPH, but again, as mentioned, it was where's the disease located? So how are we going to approach that? BPA is also not gold standard, but is offered. It's an option for inoperable disease as well as residual pH after a patient has already undergone a PTE. And then, of course, we have medical therapy such as real SIGWAP. So the decision-making process is kind of once you figure out the location and things, you kind of think of the entire approach. So is it surgery? Is it going to be PPA? Is it going to be meds? And you got to take an algorithmic approach. So surgical accessibility, then you consider PTE. Is it inoperable? Then we're thinking BPA plus or minus some medical therapy. Is it residual pH after the patient has already undergone a PTE? And then, of course, the patient factors that come into play. The patient, is the patient robust? What is the hemodynamic burden that the patient is experiencing, the comorbidities? Defining inoperable CTEPH. So I'll defer to the discussants on your approach on inoperable CTEPH.
Well, I'm happy to define it. If you want to take a clip at it, it's the easiest definition in the world.
Yeah, no, I mean, it's totally dependent upon your surgeon. I mean,
There you go.
if your surgeon can get to it, it's operable.
There you go.
And
Perfect.
it's very rare that the comorbidities are so bad that the surgeons won't operate. I'm always amazed at the folks we take to the OR. There's
I-
no size too big, no, we
Well,
can do
yeah.
everything.
Again, I'm being actually a little silly, but it's true. And the reason why I bring it up is operability is just a technical decision. I look at the surgeon and said, "Can you operate on that?" And he goes, "Yep." Okay, it's operable. Okay. Can you operate on that? Nope. And again, that opinion is going to vary depending on the level of experience of your particular surgical group. Some surgeons have done 0, 1, 2 PTs. Some surgeons have done thousands. And so their capabilities actually improve, especially with the appropriate tools. People take that out of the equation. I mean, it's different doing a segmental and subsegmental endarterectomy than it is doing a proximal vessel endarterectomy. And your ability to do that. And that's what defines operability. And the reason why I bring that up is so much of what is on this slide, very nice slide, what is on this slide is other considerations that make you potentially non-surgical. Okay. You may be operable, but surgery may not be in the cards because of other various reasons. And unfortunately, a lot of the studies that come out, they don't make that distinction. Particularly numerous drug studies, so on and so forth. Whether it's inoperable, the people that are non-surgical but truly are operable are still in that mix. And so the data gets a little muddy in reading some of these studies, which is the reason why I think our vernacular needs to change as we move forward in this patient population. Is this an operable patient? And or is it operable and non-surgical? So the United States Registry actually did separate out their patient groups and they're different in their mortality risks, so on and so forth. And sometimes people can be non-surgical simply on the basis of the patient refusing to have the operation. And the data, and we have a data set that actually addresses what their 1-year mortality is that you're in that group and how you respond to medical therapy. Because don't forget, if you have a lot of proximal operative disease or occlusive disease, medical therapy the efficacy of medical therapy is going to be less, and for logical reasons. Okay. Good.
All right.
There you go.
So everything was stated that's on this slide. So I'll go on to the next slide.
Oh, did I? I'm sorry.
No, it's good. Thank you. Back to our patient, came to us, was started on the Olympus and diuretics, referred to our CTEF meeting, which is a multidisciplinary meeting with CT surgeons, pulmonary vascular disease docs, radiologists, and as mentioned earlier, diagnostics was the next step. Where are the lesions? How do the lesions look? So we got a CTA.
You're gonna tell us what you're seeing, or?
Oh, sure. I was going to leave that up to you guys. So on,
You want to go back up to, okay, this is a nice example of how, I'm an old guy. Obviously, I'm the grandfather, right? Terry? All right, already. Anyways, to me, that's why I always want to see a perfusion imaging. It can be SPECT scanning, it can be whatever. I want to see where the perfusion abnormalities are. Okay, it helps me focus my eyes on CT or conventional angiography. What am I looking for? And in this case, what was it? The right upper lobe was bad?
Yep.
Okay, so if you go back to the right upper lobe, that's where you're going to focus a lot of your attention on the proximal, on the vessels. We went through it. I know it's really hard to do presentations.
it's going back.
I know it's going to go as fast as it's going to go. So, but again, I'm talking too much. Why don't you guys interpret?
No, you're doing great.
Oh.
You'll cut us off anyway.
Oh,
100%.
hey,
I'm just kidding.
what you talking about? But again, I'm a little taken aback in that there are clearly segmental level vascular narrowings. There is some decrease in the vascular density throughout various parts of the lung field, but not holy cow big stuff.
Mhm.
Okay.
Other than the PAs in the right heart, but
Yes,
they're
other than
gargantuan.
the PA in the right heart.
Yeah, they're
So
huge.
again, that looks like primarily, okay, little surprising based on his lung scan, but so the CT here would suggest he has primarily segmental level disease. Now, this is where practice varies a lot across the United States and between even expert CTEF groups. What do you do now? Some groups and surgical groups feel very comfortable that they can look at that. This is segmental, it looks pretty far out. Let's call up our interventional friends and see what we can do. But important to understand, and the data is really clear, and I'll talk about that in a minute, that CT angiography still has trouble, interpretive difficulties. Now, we're talking, all of you are pretty pro at this stuff, but we're talking about, in general, CT angiography is very difficult to diagnose and localize segmental and subsegmental disease. In the old days, when I was just the nephew of CTEF, Okay, we didn't worry about it too much because we couldn't get the distal stuff out anyways. This is pre-BPA, but it's really, really important now that we have that option, that we make the distinction whether this is operable, proximal versus segmental and subsegmental, in which BPA may be the preferable approach. But CT, I still have difficulties reading it completely. And the diagnostic sensitivity is not as good at the segmental and subsegmental level on CT. It's superior at the more proximal level, but not so much here. So this is raising questions. So the test to do then is,
Angiogram.
there you go.
We did it.
Come on, man, I'm
But I do
feeding
not have, I did not include that.
Although you could argue you could do a dual energy CT with iodine mapping if you had that, which a lot of centers don't. You all do at Duke, I believe. We certainly did at San Diego, but this was also 4 years ago, so maybe you didn't at the time. That's probably better for segmental and subsegmental disease.
It gives you, it gives you, again, a perfusion. It gives you an idea of the level of perfusion. And if it showed that big upper lobe stuff, but I can show you hundreds of examples in which the case went from inoperable to operable based on pulmonary angiogram.
Mm.
Again, depending, and particularly at Duke, which has been in the game from right at the start. You know, segmental level endarterectomy is not only possible, but probably preferable.
Yeah.
And so the next thing I would do here would be a catheter-based pulmonary angiogram to better define, basically do surgical mapping.
So we did the PA-gram, and the patient was determined not to be a surgical candidate. Therefore, we went ahead and proceeded with the BPA. She underwent her first BPA on November 1st. Her pre-procedure hemodynamics, she had a mean PA of 46 and a PVR of 5.8. Following that, she had a PVR of 4. She also noted functional improvement. She had some improvement in her 6-minute walk distance and had no complications following the procedure. This further prompts the question of the role of medical therapy in coordination with BPA. So should we just put patients on medical therapy? Should we also use it just as a bridge once they get the BPA done? Should we pull off the Rio Sigwat? How could we approach that? So definitely Rio Sigwat is a bridge to the procedure, or it definitely can be an adjunct as well. It improves hemodynamics pre-BPA, and it helps facilitate a safer procedure. Now, this was further studied in the race trial, which studied the Rio Sigwat versus upfront BPA in inoperable CTEPH. And it showed that both had improved hemodynamics and exercise capacity. However, BPA at their primary endpoint, 26 weeks, had better improvement in the 6-minute walk test, as well as decrease in the PVR. And essentially, there's little evidence for some of the other medications that we use in PAH to use in CTEPH. So the main thing here is that we've been taught is optimize medically before and while you're planning for your BPA. So she went on to get some more BPA. So she came back in November and in March of 22. She underwent her second BPA in 2022. Her right calf showed a PA pressure of 48, post-procedure 46, and her PVR decreased from 5.8 to 5.4. RVSP significantly improved 64 to 33, and her 6-minute walk distance improved from 264 feet to 867. I'm going to ask the group, what is your next step? And when you do a BPA, now she's had 2, how many do you actually do? And what are you looking for?
You know, it's funny that we do a conference, and I'm very lucky to get a chance to know this guy because he's actually set up the BPA Alliance nationally, and we do an evening conference, and then we do a yearly meeting. And I've had the opportunity now twice to have this question as the topic of discussion, and I don't think I'm any smarter after having given those talks. So what I can say is that
Great talks, though.
Oh, thank you. No, I struggle with these because I don't think there's a right or wrong answer here. I mean, I think this is where, we talk about discussing things with your patient and coming up with a mutual plan. I always ask the patient, what do you want to get out of this procedure? Because, for some of these people, you're going to find they have so many lesions that you could bring them back 10 times and dilate all these different things. And there are other patients that, if they're selected properly, that is. And then there's some patients in whom, they don't tolerate the procedure well at all. They don't like lying on the table. It's torture in there for them. And so I asked them specifically, what do they want from the procedure? Do they want to come off of oxygen? Do they want better quality of life? I mean, these are all important questions. Now, one thing you can see is that we didn't do a very good job about bringing people back, right? Because, November of 2021 and then March of 2022. So it took me 4 months to bring the patient back, which is disappointing, but that also says how often, how busy our practice is and how tough it is to get people back. But typically it's going to be around 4 or 5 sessions. You can look at certain things. You can look at exercise tests. You can look at quality of life. You can look at, improvement in hemodynamics. You can try to normalize hemodynamics, but most times we don't normalize hemodynamics. And it's a combination of various therapies, including medical therapies that we end up utilizing.
I think two quick points to add because Rich just mentioned that we don't still have like what is the right endpoint for when to stop BPAs, and it could be like Pringles. Once you pop, you don't stop. But and I think that's actively being studied. But I think that another thing that we don't understand is who isn't going to respond or not respond adequately. This patient's post PVR after the first BPA was 4, and she's coming back with a repeat PVR that's even higher than her initial PVR at the first BPA cycle. Is she a non-responder? I would say no, because it's only been 1 session and 4 months in between. But there are definitely a small subset of patients who don't respond, and we have not adequately phenotyped those patients. And then the last thing I'd say is there's recent data. This wouldn't have been germane in 2022, but there's recent data that continuation of the riociguat post BPA from Shimokarahara, or the Japanese group, which is where a lot of the BPA stuff comes from, is actually beneficial without excessive adverse events. A small study needs to be expanded upon, but this is maybe a patient where continuation of the riociguat post BPA, whether you're going to do additional sessions or not, would be thoughtful moving forward.
The other thing to add is that the other thing from race is that one thing that was interesting is the people that got upfront therapy before they got BPA had a lower risk of complications, and that, things like hemoptysis, and these are all important things to worry about when you're doing procedures like this.
And that was actually the, the most notable result of this particular study. It's called the race study. And what they initially, as there was a parallel study that was done. It's called Mr. BPA that was done in Japan. And what they were originally going to do is which is better, if I do BPA or if I put them on Rio. Okay. Meaning not if I put them on pH therapy, it's just if I put them on Rio. Okay. And then those patients, not all patients got to a level of pH that's desirable, so they flipped them over. And so if you first got BPA, then you were placed on Rio, and first got Rio, then you had BPA. A lot of difficulties with the study, but at the end of the day, both groups came down to the same level of pulmonary fat hypertension improvement. And so what Rich said is absolutely true. Again, this is the biggest hole that one of the holes that we're dealing with in the BPA world. And the reason why I asked Rich to give the talk, because he does it right. He talks to the patient. What does the patient want to achieve as a result of BPA? Because you don't often get them down to a normal set of hemodynamics. There are some groups, and they report this out, who will keep on doing BPAs as long as there are targetable lesions. There are groups that get it, I'm going to keep on doing this until I get down to a certain level of pulmonary hypertension, so on and so forth. BPA is evolving, and what best to measure, I think, is exemplified by Richard, by Dr. Krasuski's approach, in that what does your patient want and how does that work into their care plan?
I think that makes a lot of sense. That's very helpful. I know in the race trial, people had oftentimes more than the average number of BPA procedures. I think most people had like 6, but I haven't looked at the trial in a while. On average, how many lesions do you think you're actually going after, or how many times are you typically taking patients for BPA?
Yeah, it's a good question. It really varies patient to patient, but I would say, I often say one of the stopping points is for each procedure is, how much I'm able to tolerate, how much the staff is able to tolerate in the room. I can tell like I could go for hours, but I look at my staff and they're all looking dead tired and they're all like, "Oh, when is he finally going to say call it a day?" I'll typically go as long as like my contrast limits and things go, but it's going to be usually we probably intervene on maybe 12 to 15 lesions in maybe 3 or 4 segments or subsegments. So, that's a reasonable number. I always stick to one lung at a time. I think the worry about creating reperfusion injury was there at the beginning. I can tell you I've probably seen reperfusion injury once. And again, I don't want to knock on wood and, jinx myself the next time I do this, but I've stayed away from that. I've been a little bit less in the way of aggressive, but I think you do as much. And then again, the patient too. If the patient's tolerating the procedure fine, if they're constantly saying, "Oh, my back hurts, so I can't do this," or then you're going to curtail your procedure a little bit. But I would say 12 to 15 is a reasonable number of areas that you end up ballooning, and it's maybe 4 or 5 inflations of the balloon in each spot. So these are tedious procedures. I notice my fellow will disappear oftentimes during the day. "Oh, I've got a TAVR to do," and then it's like I'm in there alone with the tech, but that's fine. It's
That's good for you.
yeah, exactly. Works on my
I
strength.
just checked. We're covering what he was going to cover. So, and I know we have a time limit, but I did want to make a couple of points. Guys, I could talk about this for days, but listen, a couple of points. You saw that Rio Sequoia was started as soon as the lung scan came back positive, and this was felt to be potentially CTEP. And don't forget, Rio is FDA approved for those patients who have inoperable CTEP, as well as those patients who have residual pulmonary hypertension following um, um, following an endarterectomy surgery, but also approved for PAH. Okay, CTEP is a complicated disease. Okay, and and this is the point for this patient. CTEP is a complicated disease. It has obstructive occlusive vascular disease, both proximally and distally, which makes endarterectomy surgery and BPA logical. But it also has a component. It's a bicomponent disease. There is a secondary small vessel vasculopathy that develops pre and post capillary vasculopathy that can develop in this patient population as well. That makes medical therapy also very logical to start. Okay, medical therapy. All right, and so whereas Rio is FDA approved for this indication, um, just it's not the only drug. At a certain point, once you're done with the occlusive vascular disease, you have to approach these patients and if they still have residual pulmonary hypertension, as they are patients with small vessel disease as well, and you have to approach them in a manner that makes sense. Okay, so the addition of more pH medical therapy may be appropriate in this particular patient if all the lesions have been addressed. And that's the point. That's what race didn't address. They said, you mentioned sessions, 7.7 was the exact number. Okay. But how many vessels did they attack? 10, 15, 30, 80 million? Okay. They didn't indicate that. Okay. And all patients are not the same with inoperable disease. You may have 15 lesions that you can easily address with BPA, and the rest of it's small vessel disease. Or you may have a patient in which the small vessel disease may be the predominant feature of their CTEP. Okay, so they're very different. And when you treat these folks, okay, you got to think about what's the predominant part of the vascular bed that's involved here. Okay.
You see this, Melvin, you didn't actually have to make a slide deck at all. Bill would have
Yeah.
just done the talk for you. So.
I could do this all day.
But I think that point's important because not a lot of you are at a CTEF center, and the referral sometimes takes months. And so if your PVR is 7 and your mean PA is in the 40s, I think you should treat it in the exact same way that we just spent hours talking about dual oral therapy up front. And maybe instead of a PD5, you do Rio, and then you do an ERA. I think
Just know that surgery shouldn't be delayed because
correct,
Right.
correct.
Make
But the
that
referral
mistake,
might
guys.
take a while.
Okay,
Yeah.
just you're trying to make the patient better, Okay, there are no data out there that suggests that pre-treating operable patient with medical therapy, okay, is going to improve outcome.
Correct.
Okay, there are no data out there. What can be problematic if you say, I'm gonna see what happens after a year on medical therapy. Meanwhile, you got a patient with clearly operable disease that you could potentially cure with an operation.
I don't have a question. I was just respectfully going to say we probably should move on for the sake of time. But thank you uh, for your presentation and to our panelists.
Give Melvin a chance to give his last slide, right? He's summarizing. I think,
Come on.
actually, yeah, go ahead.
Oh,
Summarize for
sorry.
it, 'cause, you know.
The key takeaways was everything that you guys discussed. So
No, but it's a nice, it looked like a nice slide there. We can go back to the last slide.
Bring up his,
Just bring up the deck with the last slide if we could. Please. We kind of took it away from him, you know, he deserves to have closure.
slide 21.
Especially if you hung out for the whole BPA session.
I know. But this patient, I don't remember who this was, to be honest with you, but it's nice that she had a nice result, so.
So key takeaways, it takes a multidisciplinary approach in deciding how to proceed with these patients with CTEPH. PTE remains the gold standard, but depending on the location of the disease, if it's considered inoperable, BPA is effective and safe, but it's important to note in expert centers with people who are very used to these doing these procedures, given the risk of them. Medical therapy plays a role in bridging therapy as well as in addition to, and of course, you have to take a technical tailored approach to each patient.
Great point.
good job.